Thank you. Okay, so our next speaker is actually Dr. Anthony Barale, a consultant psychiatrist at Sechelt Hospital, who works primarily in our inpatient psychiatric unit and provides consultations in our medical, surgical, and maternity wards at Sechelt Hospital. He spends a lot of his day assessing and treating youth and adults in mental health distress in our emergency department. And prior to specializing in psychiatry, he worked as an anesthesiologist in South Africa, and after immigrating to Canada, served in the emergency room as an emergency room physician at the University Hospital in Saskatoon. And here today, maybe even jet lagging a bit, thank you very much for coming home, he is here to discuss some of the myths and realities of cannabis.
Good evening, ladies and gentlemen. Thank you for that, Jane. And yeah, forgive me if I sound a little flat. 14 time zone jet lag is tough to get over. It's about 2 in the morning for me right now. So, cannabis. I titled this Some Myths and Realities. And why some? Because I can't possibly do justice to the complexities inherent in what is becoming a huge and wide-ranging topic. A topic generating a lot of excitement, as you know, since legalization, and the trend also to popularize cannabis as a medicine. It's very much front and center in our social discussion these days. So myths. Cannabis as a medicine. This is myth number 1. It may come as a shock to a lot of you. Cannabis is not a medicine. It is indeed potentially dozens of medicines. And so there's this myth that we are taking a medicine. In fact, we know of at least 50 psychoactive substances in cannabis. Those are substances that act in the brain. There are probably more. There are a couple of hundred chemically active substances in the cannabis plant. So when you are inhaling or consuming cannabis, you are consuming dozens of medications with varying degrees of effect and in various sites in the body. So that's myth number 1. Why are we at this point where we know we're only just beginning to learn about cannabis and we know so little about it in detail? Well, the good old USA in 1970 decided to ban research on cannabis, but not only on cannabis, on other plant substances, including psychedelics, psilocybin, and a lot of potentially useful drugs. So things ground to a halt around the world because the world copies America. So we come to this point in our history where cannabis is becoming acceptable, decriminalized, legalized, and yet we know not enough about it. We're only just beginning to do good research on it. Interestingly, there was one country that didn't ban research on cannabis. Anyone know? Israel. Yeah, Israel continued to research cannabis, and in fact was doing so in the 50s. I had the privilege of speaking to the grandfather of cannabis research, Avi Meshulam. He's in his late 70s now, who synthesized THC for the first time, extracted it for the first time from cannabis in 1958. And his research group has continued with that to this day. And they have some of the most robust scientific research on cannabis for pain and schizophrenia, amongst other things. So that's myth number 1. It's not a medicine. And it's become obvious that we have cannabinoid receptors in the body. There's CB1 and CB2 receptors. They are different in the brain to the rest of our body. And that adds another layer of complexity to how we use cannabis and how we'll use it going forward. Myth number 2, cannabis is well demonstrated to be of value in psychiatric conditions. That may come as a surprise that it's something of a myth still. If we use what is accepted evidence these days for medicines, and one can argue rightly or wrongly whether it's the right type of evidence, and those are called randomized control trials. Double-blind randomized control trials are the standards in science. for determining whether a substance or a procedure is really effective or not. Because of the ban on research, we have very few of these for mental health conditions. Depression, no control studies. Anxiety, one controlled study with cannabidiol, one of those substances that I mentioned, those psychoactive substances in the brain, in cannabis, with some good response for anxiety. But it's just one randomized controlled trial. There are obviously going to be a lot more going forward. And the cost and dose is a difficult factor with cannabidiol, and I'll come back to that. ADHD, a number of randomized controlled trials, all negative. Insomnia, one randomized controlled trial. It works, but there's quite rapid habituation and tolerance developed for cannabis as a sleep aid, which means you're having to use more and more with potentially some side effects. Some people I do know, this is anecdotal, that they don't have this habituation and it works for them, fine. Once again, strains and dosing and type of cannabis, which I'm not an expert on, Mr. Keller may speak to that, becomes an element. Exciting for me, particularly is schizophrenia, the role of cannabinoids in schizophrenia. There's a few randomized controlled trials now, especially out of Israel, Meshulam's group, where high doses of cannabidiol, one of those extracts of the cannabis plant, is effective in some components of schizophrenia, particularly what we call the negative symptoms in schizophrenia, which we have no treatment for in conventional medicine. We have treatments for the positive symptoms of schizophrenia, the hallucinations, the delusions, but often schizophrenic patients are left with this residual negative symptoms, which is the anergia, the lack of drive, the difficulties with thinking. CBD in high doses, unfortunately, which makes cost an issue, and we're talking, for those of you who are more familiar with dosing, 200-300 milligrams of cannabidiol a day, which I don't know, once again, Mr. Keller may speak to the cost of this, but 20-30 milligrams of cannabidiol a day runs at $100, $120 a day, so you can imagine, a month. So you can imagine what 200-300 milligrams of CBD would cost. One hopes with time that that cost will come down. So myth number 2, there is still limited evidence for, scientific evidence anyway, for cannabis products in psychiatric disorders. What valid other evidence do we have for the role of cannabis in medical conditions? Well, it's been long known that it's useful in chemotherapy, nausea, and one of the extracts of cannabis, nabalone, is in a pill form and highly effective. Inhaled or consumed cannabis is also effective for chemotherapy nausea, which is huge for chemotherapy patients. Epilepsy in childhood, there are good randomized controlled trials for some forms of epilepsy that are resistant to conventional treatments. Once again, the Israeli studies are prominent in this, but other studies as well. Chronic neuropathic pain, good evidence for cannabis products for chronic neuropathic pain, that's nerve-based pain. Not particularly good evidence for other type of pain, but nerve-based pain is very useful. Very useful in the spasticity of multiple sclerosis, cannabis products, and spinal injury patients who have contractures, spasms. So that's been a breakthrough. It's also been shown to be useful in refractory pain in palliative care patients, and anxiolytic, helpful for the anxiety of the dying process. And then, as I mentioned, there's good evidence in schizophrenia as well. Myth number 3, it's already been mentioned by Vanessa, the myth that you read about and hear about, cannabis doesn't cause psychosis. In the vast majority of people, it doesn't. But if a young person in particular, has a family history of psychosis, and that's not always evident because it may be great-great-granddad that died in an asylum in London somewhere, and it's skipped generations, but the genes are still there. Or if they have other signs that they may become psychotic on cannabis, which includes having hallucinations with cannabis. So we see them in the emergency room. There has been an increase over the last 3 or 4 years of young people, adolescents, 12 to 19, 20, presenting with psychosis, which is purely cannabis-induced, because we check their urine, and that's all there is in the urine, and that's what they tell us they've been using, but they're floridly psychotic. The majority of those youth get well on antipsychotics and discontinuing the use of cannabis, but there is a small proportion that remain psychotic indefinitely. So this is very serious. The young developing brain is not made for cannabis. If you come in with a transient psychosis that clears up and you carry on using, with your next psychotic episode, you have a 20% chance of remaining, and this is of remaining permanently psychotic, and that's in a good prospective study following a group of youth continuing to use cannabis after their first transient psychotic episode. So that's myth number 3. It is of risk for, it does cause psychosis in adolescents, less so in adults. Myth number 4, cannabis is not addictive. Now, it's certainly nowhere near as addictive as opioids, benzodiazepines, and other prescribed and street drugs. But there is a population, a subpopulation with underlying mental illness, as Vanessa mentioned, who are prone to using it to numb out, self-medicate, whatever term you want to use, help themselves with their significant trauma and emotional issues. In this population, it is potentially addictive, both physically and psychologically. And I've met adolescents here on the coast who are virtually chain smoking cannabis to deal with their distress and anxiety. I added a myth number 5 tonight at the request of Mr. Keller. There is no fentanyl in cannabis. I know Tessa Cameron, our police officer, may comment on that, but we test everyone's urine that comes in, virtually everyone, with a mental health complaint to the emergency room. And we are seeing people who are telling us they're using just cannabis, and there's just cannabis in the urine. We haven't seen an inadvertent contaminant with fentanyl. So that's myth number 5, which I'm glad Mr. Keller reminded me of. So you may think I'm sounding very, very negative about cannabis. And I'm not, I'm just being cautious. I am, in fact, quite excited about the potential of the plant. But I think it's rather like, the broad analogy I use is one of opioids. Thousands of years ago, probably in China, someone discovered that the resin of the poppy plant was useful for sedation, sleep, and pain. And that's all they used for years, and then opium was the next step. It was extracted and distilled from the poppy resin, and that was used for hundreds of years. The Victorians used opium. And then, of course, from opium, heroin was extracted and distilled. And finally, we now today have this whole range of opioids, both those extracted from organic opiates and those that are made in test tubes, like fentanyl, sufentanil, carfentanil, blah-de-blah. So I'm using that analogy because I think we're at the opium phase of cannabis. I think it's going to take decades before we get to the phase where we are now knowing precisely what each extract or distillate from cannabis does and how to use it and at what dose. But that's exciting. We're on that path. And I think it's tragic that we've had to wait, what is it? I'm doing the math quickly, 47 years before we can start looking at the actual research again with cannabis. Big Pharma had tried for decades, usually in the 80s, 90s, and 2000s, to make useful medicines in test tubes and on computers. So they were designing molecules on computers and then making them in the test tube. And it cost them a fortune, and it took anywhere from 2 to 10 years to get anywhere near a stage where they could start trialing it in animals. And they eventually realized they weren't winning. So big pharma and university researchers are going back to the forest. They're going back to the jungle. And because nature has been making substances for hundreds of thousands and millions of years. Aspirin, digoxin, multiple antibiotics were all found in the forests, in animals and in plants. And Big Pharma is realizing that that's a more efficient way now to find medicines, and cannabis is an example of that. There are other drugs being developed from psychedelic substances in forests. There's dimethyltryptamine, the component in ayahuasca that research is being done with just down the road in Seattle and San Francisco. Psilocybin from magic mushrooms, once again, is almost legalized in America. They're on stage 3 trials, highly effective for PTSD, alcoholism, and a variety of other things. So we've gone back to the plants, and I think cannabis, rightly, is an example of that. So while randomized controlled trials are important before we just launch into using cannabis, I don't poo-poo direct experience. Mao Zedong, of all people, said, the most convincing evidence comes from direct experience. So if cannabis is working for you, an extract of it, cannabidiol, usually with minimal side effects, and if you have full knowledge of the potential long-term problems with the substance, then good for you. That's fine by me. Especially if it's helping you avoid potentially addictive substances, opioids for pain, benzodiazepines for anxiety, then I think there will be and is a role for some cannabis products. But as physicians, we're only just beginning to use that. Ironically, some of our weed store people know a lot more about it, and dosing and so forth. My other worry is, though, on a closing note, is that in our Western society, with our allopathic approach to medicine, which has grown up in the last 400 or 500 years, where we pursue medications to fix, medication X to fix problem Y, we've developed an attitude as a society that medicine should produce one quick fix for our problem. The fact of the matter is, certainly in psychiatry and in most of medicine, everything is what we call over-determined. And that's a fancy phrase for saying that there's no one cause usually for your anxiety, for example. And therefore, there's no one quick fix for your anxiety. Your anxiety may have a genetic basis. It may be based in trauma in childhood. It may be based on poor relationship issues. Excessive alcohol consumption is usually more than one cause for your anxiety, and hard work has to be done to deal, for example, with your anxiety beyond just hoping that one cannabis extract will help you. Diet is critical. As Mr. Keller and I were discussing earlier, prebiotics, probiotics, exercise, sleep, a holistic approach. Cannabis will be just possibly one pillar of your recovery and treatment. So I'll leave it on that note and look forward to the discussion. Thank you.